So good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick, joined by my amazing vice chair, Bonnie Collison, who did a great job, impressive job on the floor today. She defended 7 amendments. And you did it with such grace. Thank you so much on behalf of the committee. I'm going to go through some of the rules that we have here. But before we do that, we do have the first bill is jointly assigned with appropriations. And I want to give them a chance to introduce themselves to you. And they're my wonderful colleagues. Why don't we start to my right?
Thank you. Thank you, Madam Chair. It's wonderful to be in this lovely, lovely room with all of you amazing people doing all the incredibly important policy work. I am Delegate Emily Shetty, Chair of the Health and Social Services Subcommittee on Appropriations. May I introduce my colleagues?
Please.
From our subcommittee today for our jointly assigned bill, we have Delegate Malcolm Ruff, our newest addition to HSS from Baltimore City. Doing a great job, and our favorite Republican, Delegate Jim Heinbaugh, representing Western Maryland, doing a great job on our subcommittee too. So thank you so much for having us today.
Wonderful. And who's your counsel today?
Oh, forgive me. Of course, I cannot forget. Joe Gutt-Burlett, counsel to HSS subcommittee. Thank you.
Wonderful. Our counsel today for these bills, the subject matter is the amazing Aaron Hapwood. Thank you for being here. So I'm going to go through some of the rules just quickly. Will you be so kind and set your electronic devices to vibrate? Because sometimes you get some funky music, right? Unless it's merengue or salsa, you know. Maybe I'll let you do that. As a reminder, there's no food or drink allowed in the gallery because our staff do not have the time to clean. They are very busy. You'll see us that we're drinking here. It's because we are here for hours and we need to stay hydrated. For each bill hearing, we're going to hear from the bill sponsor and the sponsor panel, followed by an all in-person witness. It'll go favorable with amendment, and unfavorable. Sometimes I alternate if there's a lot of witnesses just to be fair and balanced. I have decided in this committee not to time the sponsor, but please don't take advantage of that, okay? Don't make me have to tell you to wrap it up. The witnesses that are not sponsors, that are not actually the bill sponsor, you get 2 minutes to provide your testimony. And there's a timer that is displayed on the screen. And when it goes off, I'm not going to be rude. I just want you to make a mental note and wrap it up, okay? For the committee, you're working really hard, and I want to thank you so much for the work that you're doing. And last night we were all here, all 23 of us were here very late. And the days are going to get longer. So I'm thanking you for that in advance as well. But please adhere to the usual committee rules of 1 question and 1 answer. And please keep your question brief. Remember, you can talk to people offline or send an email as well. And we do a lot of work here in subcommittee. Members of the public are able to view us live stream. So be careful with your conversations because we do have something new this year, which is the captioning, which is amazing, but it does capture your conversations, and you may not want that conversation out there. So today we're going to hear the bills in the following manner. However, I may change it, and I want you to give me the grace to allow me to do that, depending on whether my colleagues have if you don't see them in their chairs, they have bill hearings in other committees. It's not disrespectful. We read everything that is presented, and we also see the video. We're going to start with House Bill 1104. That is the Maryland Department of Health, the AHEAD model implementation, electronic healthcare transactions, and population health improvement fund. And this bill has been jointly assigned with Health and Government Operations Committee. And then, jointly assigned with appropriations. Oh, yeah. Well, what did I say? Jointly assigned with appropriations. Thank you. Then we're going to go to House Bill 798, followed by 804, 884, 996, 729, 783, 743, 737, and 870. However, I may change it, okay? Why don't we get all the witnesses for House Bill 1104? Will you please, the panel, please come up and bring whoever's with you. I have Andrew Nicholas, and I have virtual. I have David Sharp. Will you please bring the virtual witness up as well? And that's what I have for this bill. Good afternoon and welcome.
Good afternoon.
How are you?
I'm well. How are you?
Good. Will you be so kind and move it closer? You can actually move it. Thank you. Yes, it's ready.
All right. Well, good afternoon, Chair Pena-Melnick, Vice Chair Collison, Chair Shetty, and members of both committees. My name is Elizabeth Edsel-Crom, and I'm the Assistant Secretary for Population Health and Strategic Initiatives with the Maryland Department of Health. The department supports HB 1104. My testimony today is going to focus on the Population Health Improvement Fund. One of the required elements of our signed state agreement with the Centers for Medicare and Medicaid Services for the AHEAD model is that Maryland must create a dedicated fund for population health improvement. HB 1104 authorizes this fund to be established. The work supported by the fund must align with the AHEAD model's state health equity plan. This plan defines our population health measures and targets, and it guides the state's model's activities aimed at meeting those targets. This plan is under development right now. It's due to CMS by July 1st. The Maryland Commission on Health Equity serves as the governing body for this plan's development. And that group actually has new members as of October. The membership has been expanded and now includes representatives from hospitals, health systems, and other clinical providers. The department intends to develop a set of guidelines to outline the eligibility criteria and descriptions of funding categories, as well as regular reporting requirements for this fund. We're going to seek feedback from stakeholders as we develop these guidelines before finalizing them. We also plan to establish a review team to evaluate applications to the fund. Given that this is supposed to be a pooled fund, so it's supposed to take in both public and private sources of dollars, hospitals and any other organizations that contribute to the fund will have a seat on the review team. Population Health Improvement Fund provides the pathway to align resources to invest in the factors that we know drive better health outcomes for Marylanders. And we appreciate your time and your consideration of this bill. Thank you.
Hi, good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Andrew Nicholas. I'm here representing the Maryland Hospital Association. The Maryland Hospital Association fully understands and supports the purpose of this bill as far as coming into compliance with the AHEAD model. We are supportive of the goals of the AHEAD model, as you have heard already from us on this, on AHEAD and where we are in that process. And let me just say, for this bill, we are very appreciative. The department has been we've had a lot of engagement with the department on this bill. They've been very accessible. We do have a number of issues or areas of concern that we are working through with the department on. We've had very productive conversations so far, and we look forward to continuing to refine those issues to bring greater clarity and understanding to how the bill will operate and be implemented going forward.
David, you can provide your testimony. David, can you hear me?
I can. Good afternoon.
Go ahead. And I call you David because I know you for almost 20 years. But Mr. Sharp, go ahead and give your testimony.
Please. David is just, thank you.
Go
Okay.
ahead.
Good afternoon, Chair Pena-Melnick and members of the committee. The Maryland Healthcare Commission supports.
Up a little bit, David. Will you, can you get closer and put the volume up a little bit?
Let's try it. Okay.
Yes.
I will make sure I'm using my baseball stadium voice.
That's good.
So from the beginning, good afternoon, Chair Pena-Melnick and members of the committee. The Maryland Healthcare Commission supports House Bill 1104, which clarifies that electronic healthcare transaction data may be used to support the state's participation in the Advancing All-Payer Health Equity Approaches and Development model. Current Maryland law allows the use of electronic healthcare transaction data for certain public health and clinical purposes. However, it does not explicitly mention the AHEAD model as an authorized use, which creates uncertainty for electronic health networks regarding the permissible use of such data. Electronic health networks route administrative transactions such as claims and eligibility data electronically between providers and payers. By updating the statute to specifically include the AHEAD model, This will resolve electronic health network concerns and clarify that electronic healthcare transaction data may be used for broader goal of advancing health equity and improving population health outcomes. House Bill 1104 is a crucial step towards enabling Maryland to meet the AHEAD model's performance requirements and goals of improving health equity and population health. The bill ensures that Maryland's data sharing infrastructure continues to evolve in support of the state's ongoing healthcare transformation. Chair Pena-Melnick and members of this committee, this concludes my testimony, and for this reason stated above, we respectfully request a favorable report on House Bill 1104.
Thank you for your testimony. I am going to hand it over to my co-chair, Chair Chetty, for her colleagues and she to ask questions first, okay?
Thank you, Madam Chair. I appreciate it. I appreciate the opportunity to be here today to review this. I am a big supporter and fan of the total cost of care model and really excited about what the next version could bring, particularly when it comes to health equity outcomes. I think it's long overdue. And so thank you for all of your incredible work. I am interested in understanding a little bit about how we might be able to address a longstanding issue related to challenges that we're seeing in Medicaid in particular when it comes to reimbursement for really necessary procedures like in the specialty provider space and how it relates specifically to children in Medicaid and health outcomes that they're facing as a result while providers pull out of actually being able to provide these services. So specifically on my mind is pediatric anesthesiology and the differential in rates there. And I'm wondering if there might be an opportunity for consideration for a tie-in to some of that longstanding work that this body, this committee, and our committee has been concerned about, and whether there might be an argument to be made on the health equity issues that arise when children don't have access to these types of services. So I know this is probably a question for offline, and I know I've spoken with HSCRC about this privately, and so I'm wondering if maybe if you have any immediate thoughts on whether there might be a potential tie-in here, but I would love the opportunity to also continue the conversation with you for possible amendments to this bill even as we're moving this forward.
So we'd love to be able to continue the conversation. I'm not the right person to answer this for you today, but if we could take it offline and add some others to it, including Medicaid, as well as the HSCRC, that would be great. But as you know, the overall tenets of this model is really to improve the affordability, accessibility for all Marylanders, right? So what you're outlining is something that we don't want to leave anyone behind. So if we could, that would be great to continue that conversation.
Are there any questions? Okay, now I'm going to open it up for our committee. I see first Delegate Shilega, followed by Delegate Taveras.
Thank you, Madam Chair. Thanks for being
pleasure.
here. The first sentence in the fiscal summary in the fiscal note says HSCRC special fund revenues increased by $25 million in FY26 from the assessment. What can you tell us about that fiscal note and what the assessment is?
Sure. So back in December, the HSCRC commissioners voted for a one-time $25 million increase in rates for calendar year 2025. And so to support this fund, contingent on the creation of this, the fund through this legislation. So what that means is basically hospitals are going to charge commercial payers, Medicare and Medicaid, a small amount more than they otherwise would for services. And then those dollars would then be assessed back to create to go into the fund.
And then ongoing?
So that was what was approved was a one-time use of those funds.
But then you'll need ongoing money.
So in the legislation, it does say that the HSCRC may assess, yes, other funds.
I mean, I'm assuming you'll know what, you're not just are you going to be one and done?
So the process for how funds could be assessed, like what was passed back in December, that goes through an entire process with the commissioners and requires a vote through the HSCRC and their commissioners. So it's not something that I can speak to say that we will. The HSCRC with their commissioners and their process would have to go through that.
Thank you.
Delegate Taveras.
Thank you, Madam Chair. And I understand that, and welcome, thank you so much. I understand that we're looking at a population-centered model. However, when we're looking at total care, how are we addressing some of the concerns with regards to infrastructure depreciation, the need to save in the hospital system so that they could be able to keep up with innovation?
I think that's an excellent question. And so the Population Health Improvement Fund, as outlined of what we have to do for our state agreement, those dollars need to be used to support the state health equity plan. And those measures and targets are under development now, but those are to improve chronic conditions, preventable chronic conditions, avoidable utilization, other things that will improve overall population health, particularly where we see disparities in health outcomes between groups. So it does not address the issues of depreciation or capital expenses.
It does not.
It does not. This fund is specific for the purpose of meeting the goals of the state health equity plan as outlined in our state agreement with CMS.
So how will they be able to address that?
So that is a question I'm happy to take back to the rate setting commission, but that is not something that I can speak to related to the Population Health Improvement Fund.
Thank you. Any other questions or concerns? All right. Seeing none, thank you very much. Really appreciate your time and all your efforts
Thank you.
to keep Maryland healthy. This actually concludes the bill hearing on House Bill 1104. I want to thank Appropriations for joining us, and you're welcome here anytime, all right? Thank you. And this concludes the bill hearing on 1104. We're going to go next to someone that I know really well, and you see her picture when you come into the committee. House Bill 798, Delegate Lehman, Opioid Restitution Fund Interactive Dashboard. Will you please come up? I also have, I think, on your panel, NCCA, Kristen Pendergrass. And do I have Carrington Anderson?
Thank you, Madam Chair.
I'll call you after that panel because you're favorable with amendment. All right.
Thank you, Madam Chair. Good afternoon. It's wonderful to be here in front of the second best committee in the House. Thank you. Thank you, Chair Pena-Melnick and Vice Chair Cullison, as well as the esteemed members of Health and Government Operations. For the record, I'm Delegate Mary Lehman, and I am asking for your favorable consideration of House Bill 798, Opioid Restitution Fund Interactive Dashboard. The bill will create transparency around Maryland's use of opioid settlement funds through an interactive dashboard easily accessible to the public. The dashboard will provide access to clear, up-to-date information about the tens of millions of dollars of funds secured through one of the most significant public health lawsuits of our lifetime. As of fiscal year 2024, Maryland has received a little over $200 million in opioid settlement funds. Of that amount, $158.4 million went to the Opioid Restitution Fund, while $42.8 million was directly given to local jurisdictions. Of the $158.4 million received by the Opioid Restitution Fund, less than $10 million has been spent. Currently, there is no easy way for the public to find out when and how these funds are spent. Local jurisdictions are required to report their spending to the Maryland Department of Health, but do not report it directly to the public, making it difficult for Marylanders to track the use of these funds. Effective October 1, 2025, this bill requires the following: that the Maryland Office of Overdose Response, MORE, and the Department of Health must develop and maintain an interactive dashboard. The dashboard will be funded and maintained by the Opioid Restitution Fund. This is an approved use according to the list of approved uses for settlement funds. The dashboard, disaggregated by state, county, and municipality, must include payment schedule information, including estimated payments from opioid settlements, past spending of settlement funds, planned spending priorities, details on funded initiatives, including performance measures when applicable, and details on public hearings related to fund usage. The department must establish an online portal for reporting or uploading the required data. The dashboard should leverage existing platforms that already provide data on opioid use and overdoses in the state where practicable. Other states, including North Carolina and Delaware, use public dashboards to track opioid fund spending, and many other states are working toward this goal. In December of 2024, Moore published its Opioid Restitution Fund reporting recommendations, which stated, and I quote, Maryland's processes for sharing information on prescription opioid-related settlement funds are less sophisticated than other states and could be improved to increase transparency and public accessibility. For example, Maryland's current reporting framework does not use an interactive dashboard, which, if implemented, could facilitate access to this vital information. The department already maintains an overdose data dashboard, which tracks overdose trends. The dashboard created by this legislation could be seamlessly integrated into the existing infrastructure. Counties and municipalities already are providing this spending information to the state. Moore has approved the estimated $80,000 needed to start this dashboard, and it makes it a very cost-effective and impactful initiative. In wrapping up, I want to say that my office, Madam Chair, is working with the Maryland Association of Counties to refine the local reporting requirements, and this is to ensure that we do not create a double reporting requirement for local governments. I consider MACO's proposed amendments, which you will hear about, to avoid this double reporting friendly. So by passing this bill, we can ensure every dollar is used effectively to address the opioid crisis while also increasing government transparency. I urge your favorable report. Thank you.
You're welcome. And thank you for working with committee counsel and working the bill. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Ann Seacott, testifying today in support of House Bill 798 on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. This is about transparency. We're really grateful to Delegate Lehman for bringing the bill. This builds on legislation you all passed last year that actually required the report that the sponsor referenced. And this is the next logical step to make sure that just as the opioid manufacturers were held accountable through these lawsuits, we are holding governments at the municipal, county, and state level accountable for the money that they spend in response. So I don't know that I don't think the sponsor missed anything. So we think this is a great bill. We hope you give it a favorable report.
Thank you, Madam Chair, members of the committee. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof, which is a national nonprofit dedicated to ending the addiction crisis. A lot of the work that I do around the country is advising state and local governments on best practices as it relates to opioid settlement funds. I also lead a coalition of about 30 to 40 national organizations that are working in this space. Shatterproof was also an early endorser of Johns Hopkins University's principles for the use of funds from the opioid litigation. And the fifth of those principles encourages state and local governments to develop a fair and transparent process for deciding where to spend the money. And House Bill 798 builds on the great work already done by Maryland to increase transparency and accountability as it relates to opioid settlement funds. Over the past 3 years, as I've done this work, the most often question I get is, how are states spending the money and who's tracking it? So about a year and a half ago, Shatterproof partnered with KFF Health News and Johns Hopkins University to track as much of the expenditures as we could around the country. We collated all of the reports that were made by states or to states and documented thousands of expenditures. Nationwide, of the $6 billion received in 2022 and 2023, about 1/3 of that, or $2 billion, is unknown, meaning we do not know if it was spent or how it was spent. In Maryland, for that same time period, so calendar years 2022 and 2023, $95 million was received, but more than $29 million of that is unknown. So House Bill 798 would increase the transparency and accountability. Also, I just want to say Shatterproof hears a lot from people who have been directly impacted by the opioid crisis. They've either lost someone or they're in recovery themselves, and they want to know how the funds are being spent, and they also want to be able to have input into how the funds are being spent. So I'm very happy to see the public hearings being listed in the dashboard as well. So thank you.
Thank you. I'm going to open it up for questions now. Delegate Kaiser.
Thank you, Madam Chair. Thank you, Delegate Lehman, for bringing this. I just wanted to give you a chance to respond. The Department of Health's letter was suggesting a phase-in and seemingly suggesting concerns about future costs. Did you see their letter, and did you want to address that?
I did not, Delegate Kaiser. Thank you for bringing it to my attention. We've had good conversations with the department, and as I mentioned in my testimony, the cost is minimal, about $80,000, and they already have this existing overdose dashboard, so we don't think it would be difficult. I will take a look at that and provide a response.
I'll try to email it to you right now.
Yes, please do. Thank you. I appreciate it.
Delegate Johnson.
Thank you, Madam Chair, and thank you for bringing the bill. My question is, I see the local jurisdictions are getting a sizable portion of the funds, and I see that they are obligated to make sure they keep track and put in the financial information. Are they also responsible for sharing in the expense of maintaining the dashboard?
So thank you for that question, and we had good conversations during the interim with MACO and to a lesser extent MML, and you will hear testimony from MACO. The only concern is that they are in fact already required to report information to MDH, but it is then not been made available publicly. So they don't have a problem with, with the bill, generally speaking, but their only concern is, and they want to get at this through an amendment, that they not inadvertently be required to do additional reporting or double reporting, because they already are providing the information. The handful of municipalities, Baltimore City did its own, opioid settlement agreements, and I think there are a few other municipalities, as well as all those counties, already have to do this. It's just that MDH is not then making that information available publicly. So that's what we're trying to get at, not to create an additional burden for local governments.
All right, thank you. Thank you, Madam Chair.
Delegate Chisholm.
Thank you, Madam Chair. And thank you for bringing the bill. Since you brought it up, I looked at North Carolina's opioid settlement dashboard. It's actually very interactive, and it's quite easy to read, actually. And in there, they do have the past spending dashboard. So if we enact this bill, are we going to be able to do a look back? I know you had mentioned we're missing, we have no idea where some money was spent. Hopefully we can figure that out. And will that be included in this dashboard?
Yes.
And as a follow-up? I saw in the fiscal note $70,000 for contractual services. I'm assuming we could actually go to whoever designed this, so we don't have to reinvent the wheel to have a very functional website. Is that?
Yeah, and thank you for the question. And we actually got this idea from North Carolina. When we started researching this issue, I think it's fair to say it's a model for the country. We did learn that North Carolina, and I believe Delaware as well, negotiated this as part of their settlement agreement. It was done through a memorandum of understanding, definitely in North Carolina, but I think also in Delaware. And other states are looking to do this. I believe Maryland would be the first to mandate this through legislation, but North Carolina was our model, and the bill does specifically require reporting on how money has already been spent, because that's a question mark as well.
Okay, thank you. Thank you, Madam
for
Chair.
the question.
Thank you. Delegate Taveras.
Thank you, Madam Chair. Thank you so much for coming today.
Absolutely.
In the fiscal note, they were talking about the fact that, certain areas have a higher concentration, and the reason why Baltimore came out and did their own suit. So how are we justifying that some areas are in need of more money than others? Is there going to be a ratio created so that we can say that there is proportionality with the investment in the areas?
Thank you for the question, Delegate Taveras. I'm going to ask Ms. Seacott to answer that.
So
So, and Mako may also be able to expound on this a little bit more, but in except for Baltimore City, in the work led by the Attorney General's office in the national lawsuits, the state went in with the 23 counties and several dozen municipalities. And so the counties and the municipalities all get money directly from the settlement. So those dollars are already assigned, they're already divvied up. What the state has, in addition, in the opioid restitution fund, is being given out in different kinds of ways, including by the priorities that are set by the Opioid Restitution Fund Advisory Council. And then there's a section of it that's also provided for through grants. There was a request for proposals a few months ago, and they're making decisions based on those proposals where the money goes. So I'm not aware, and this is maybe a question for the Maryland Office of Overdose Response, if there's any, I don't believe there's any kind of formula for the state pot, because there already was some kind of formula used through the settlement dollars, which is why jurisdictions got money directly.
Thank you.
Vice Chair Collison.
Thank you, Madam Chair. And Delegate, I'm not sure if it's you or Ms. Pendergrass. So will this system allow us to account for that $29 million that's missing? Okay.
Yes,
thank you.
Yeah.
Okay, I don't see any other questions. Thank you very much for your testimony today. Thank you. This actually, I believe, concludes the testimony on this bill.
Mako.
Oh, we'll have one more? Oh, I'm sorry. The favorable with amendment, and yes, I did. So Aliyah Horton, 1 second, this is not it. What did I do? Okay, so I had Carrington Anderson, sorry. No, not you yet. You can relax, you can have a seat.
Oh.
Carrington? Yes.
That is me.
Yes.
Thank you, Madam Chair,
You're
members of the
welcome.
committee. My name is Carrington Anderson with the Maryland Association of Counties, speaking as support with amendments on House Bill 798. First, I just want to thank Delegate Lehman and her office for the work on this bill and for bringing this bill. Delegate Lehman brought this bill or the idea to us in the fall, and just really appreciate her working outside of the session to collaborate with us. And we've had a lot of productive conversations since then. So really just want to give her the shout out there. Counties recognize the need for this bill and support transparency and accountability, and think that transparency encourages public trust. Counties currently comply, like you heard the delegate say, with copious reporting requirements as outlined in the National Settlement Agreement and also the State Subdivision Agreement. We submit this information to the state, and one of our amendments would be requesting that the state upload that information on the dashboard. That way we would be taking care of the reporting end on our side, and the state would be handling making that information public. So I think we're in a really good place with the sponsor, and again, just want to thank her on that. And just want to say too that counties are not trying to get out of any sort of reporting requirements. We also cannot do that. The state in the subdivision agreement is required to audit counties annually. And then we have those other additional reporting requirements. And then our other amendment has to do with the public hearing requirements. And our amendment on that is just, we request that counties, their website is linked. Public hearings change day to day, and it would be a lot of administrative effort to go in and change that every couple of days. So we would just request that that could be linked to the county's website so the public could go on the county's website and find that information. Again, just want to thank the sponsor and the committee, and for these reasons, Mako would urge a favorable with amendment on House Bill 798. Thank you.
Are there any questions? Seeing none, thank you very much. We really appreciate your testimony today, and this actually concludes the bill hearing on House Bill 798. Next, we're going to go to House Bill 884. Is a delegate here? Delegate Vogel? No? Oh, he's not here? Is he coming?
Hi, Chairman. So Delegate Vogel's in the joint hearing room. So So I'll be testifying.
Okay, go ahead, give us your name and the testimony. Thank you very much. This is House Bill 884, and the testimony for Delegate Bogo will be given by, can you give us your name?
So my name is Mateo Garcia Arauz Frazier. Thank you, Chairwoman Peña Melnick, Vice Chair Collison, members of the Health and Government Operations Committee. Adolescents represent a vulnerable population often targeted by aggressive marketing tactics, exploiting insecurities about body image. According to a 10-year study by the University of Minnesota's School of Public Health, teenagers who use diet pills were more than 258% more likely to develop an eating disorder compared to their peers who did not use such products. Furthermore, the American Academy of Pediatrics has raised concerns about the widespread use of dietary supplements marketed as quick fixes for weight losses, many of which contain hidden or undisclosed ingredients, including stimulants and laxatives. These findings highlight the urgent need for increased oversight and consumer protection. HB 884 is a reintroduction from last year, which requires the Maryland Department of Health to compile a publicly available list of products marketed as weight loss aids. This initiative does not restrict access to dietary supplements. Instead, it empowers consumers to make informed decisions. The list will provide critical information about the marketing claims associated with these products, helping consumers distinguish between safe, evidence-based supplements and those making substantiated or misleading claims. Moreover, HB 884 is narrowly focused on products marketed specifically for weight loss, ensuring that general dietary supplements such as creatine or amino acids are not included unless explicitly promoted for this purpose. More than anything, opponents of HB 884 cite existing federal regulations, such as the Dietary Supplement Health and Education Act, DSHEA, as evidence that dietary supplements are adequately regulated. However, DSHEA does not ensure proactive monitoring of products before they reach consumers. The current federal system largely relies on post-marketing reporting of adverse effects, meaning harmful products often remain on the market until after consumers have suffered negative health consequences. Especially given the current Trump administration, monitoring and enforcement mechanisms within the DSHEA and HHA could also be weakened. One example of this delayed response in previous years is the case of Epivedra, a dietary supplement banned by the FDA only after years of documenting adverse events, including deaths. By the time federal action was taken, countless consumers had already been harmed. HB 884 seeks to address this regulatory gap by establishing a state-level mechanism to proactively identify and monitor products marked as weight loss aids. This approach will allow Maryland to act swiftly to protect its residents from potentially harmful products rather than waiting for federal intervention. More than anything, it's very important to take into account research that we have compiled. For example, we found research from a Harvard-based research team that compiled data from over 10,000 young adult women over a 15-year period, and we found that over that 15-year period, the women that had used the over-the-counter diet pills for weight control were 6 times more likely than their peers to have bulimia and anorexia. Therefore, these teenagers are particularly susceptible to the harmful effects of weight loss supplements due to their developmental stage and the psychological impact of targeted marketing. These state-level initiatives have successfully complemented federal regulations in addressing public health issues such as tobacco use, regulating alcohol sales, and addressing opioid misuse. Therefore, HB 884 follows a similar model by providing state-level oversight to fill gaps in federal regulation. More than anything, HB 884 represents a necessary and measured approach to addressing the risks associated with non-FDA approved weight loss supplements. By increasing transparency and providing legislators with critical data, the bill lays the groundwork for future policy actions aimed at safeguarding public health for our young Marylanders. The bill does not ban dietary supplements or restrict consumer choice. Instead, it seeks to empower consumers with information and protect vulnerable populations from harm. By passing HB 884, Maryland can demonstrate its commitment to proactive public health measures and the well-being of its residents, particularly its youth. I urge the committee to give a favorable report on HB 884. Thank you.
Thank you. Are you signed up?
He's on our, he works for the Office of Delegate.
Okay, thank
He's a
you.
legislative.
Okay. I'm going to open it up for questions now for the sponsor and his testimony. Are there any questions?
I do.
Delegate Johnson?
Chairwoman, sorry for the interruption, but I do want to note that we have a favorable testimony that's part of the panel. Her name is Perry Patel. She's
Okay,
part of the
so
Stripes.
I'll bring that person up before questions then.
Great. Thank you so much.
Will you be so kind and bring Perry Patel? Thank you. 1 second, please, and then we'll open it up for questions. Is the person there? Perry Patel?
Hello.
Hi, how are you?
How are you?
Good. Will you be so kind and give us your testimony, please?
Absolutely.
You can go ahead.
Awesome. Good afternoon, members of Maryland's Health Government Operations Committee. My name is Pari Patel, and I am a college student and resident of Hagerstown, Maryland. Thank you for the opportunity to speak here with you today in support of HB 844, sponsored by Delegate Joe Vogel. I was exposed to supplements at the age of 14, and as a competitive athlete, I turned to over-the-counter diet pills as a way to see immediate results. During this period of struggle, no one was there to speak to me about the dangers of these products. My friends, coaches, teammates even recommended the use of the supplement.
May I ask you, may I give you a suggestion, please? Ms. Patel, can you turn the video off and give us your testimony because you froze and it's coming in and out? Are you there?
Sure. Is it better?
Yes.
Okay, awesome. Finally, through deep research, I eventually realized that ingredients might be dangerous. But still, it was hard for me to believe because I so firmly trusted that our government would not let dangerous products like these be sold to me. I was convinced that our government would put a stop to this if these supplements were truly bad. My story is one of millions, but this begs the question: how do we expect teens to understand the negative effects of these drugs? What's worse, these products are marketed as harmless, natural, and even healthy, but the truth is that they are none of these things. They are unregulated and they are dangerous. And our young people are paying the price just like I did. We cannot allow for this to continue. We cannot allow another young person to fall victim to this industry. And we absolutely cannot allow our children to be put at risk by these harmful products. So it is time for our government to take action. Creating a list of diet pills that are accessible for consumers is a vital step in protecting the health of Maryland youth. I implore a favorable report on HB 844.
Thank you. I'm going to open it up for questions now. Are there any questions for the sponsor and his panelist? Delegate Chisholm. Delegate Johnson, you know. Okay, Delegate Chisholm.
Thank you, Madam Chair. And I'm sorry the delegate's not here to answer these questions, but I'm looking at all these ingredients and it includes everything. I mean, everything. And in New York, they've already passed this and it's had a dramatically negative effect on all of their retailers because of all of the things that are included in this. My big concern is, do you think it'll have a negative effect on even adults? Because now we're going to be putting all of these products behind the counter. So we have an adult that may have might be embarrassed that they need to lose weight. Now we're going to make them sign with an ID at their own home for this product, or we're going to make them go up to the counter and ask for this product, even if it's just a simple creatine, which I would tell you most bodybuilders take. Green tea extract. My wife is the most natural person I know. and she'll drink green tea extract. So if something has green tea extract in it, she's going to have to go up to the counter and give an ID to buy one of these products? Is that the way that the bill is written, and that's the intent of the bill?
So the intent of the bill was focused around the supporting minors, given that unfortunately there's research that shows that, I mean, right here, and I'm happy to send the article to your office.
I understand, but we're entrapping a whole population of people that may not need to be entrapped, and making them feel like they're breaking the law by buying many of these products.
Well, we'd be happy to have conversations with Delegate Vogel about potential amendments in order to consider this issue.
I appreciate that, and I appreciate you coming and giving the testimony.
Of course.
Thank you. Do you know if Delegate Vogel has worked, there's a lot of unfavorable, has he been meeting with everyone? Okay.
Yeah, so we have discussed this with the Maryland Department of Health, and happy to have conversations with the Maryland Retailers Alliance and with other unfavorables. I mean, at the end of the day, amendments are always, we're always happy to have discussions with people to solve the issues, but this is a problem that's hurting young Marylanders, and we believe that there's a reason as to why we wanted to reintroduce it to address this issue.
Okay, thank you. I don't see any other questions. Thank you so much for your testimony. I really appreciate it. Next, we're going to call a panel of unfavorable. We have Daniel Fabricant, Steve Mister, John McLuckie, and Sarah Price.
All right.
Good afternoon.
Good afternoon. Thank you, Madam Chair, esteemed members of the panel. I represent the Natural Products Association, the oldest and largest trade association in this space. I was a bit dismayed at the last testimony, as the bill does not control for creatine. I have seen movies that say Maryland is known for two things, crab cakes and football. I think you guys have seen that movie too. Crab cakes, a pound of crab cakes, have about 3 grams of creatine, which would be restricted by this bill. And also, with regard to meeting with unfavorables, our association, as well as others in the space, have asked to meet with Rep. Vogel and have not received any reply. So please let that stand for the record. I represent about 500 manufacturers, retailers in the space who make up the Natural Products Association. We are here in opposition to this bill, which imposes unnecessary restrictions on the sale and access to dietary supplements. This bill is misguided. It's led by a group out of Harvard that has been shopping this bill for more than 10 years without any real clarity of what the problem is. My prior role to this job at NPA was I was the chief regulator under President Obama. I am a scientist by training, and I can tell you that the laws that FDA has work and work well to remove products, as well as regarding the messages that FTC, the Federal Trade Commission, also has control over. So with that said, the premise that the industry needs to be treated as tobacco and alcohol, and there needs to be age restrictions, we can put crab cakes behind the shelf too and ID check them as well. So contrary to any implication that they're unregulated or any concern about a new administration and changing the laws, the Food, Drug, and Cosmetic Act is 206 amendments long, going back over 100 years. I can tell you once things get put in there, they generally, and you can check for yourself, don't get taken out. So these laws work and work well. I still get postcards from the Department of Justice on people during my time in the Obama administration that we sent to jail for violating the Dietary Supplement Health and Education Act. So with all that said, these false premises really need to go away. One thing that's very important, and we talked about it last year, is adverse event reporting. The adverse event reporting requirement for dietary supplements is the same as pharmaceuticals. For the people who claim to have suffered at the hands of dietary supplements, report it to FDA. It is also against federal law to falsify an adverse event report. So when we were here last year and testified and asked the witnesses that said they suffered an adverse event to send those to FDA, surprise, surprise, nobody sent anything into FDA. So with that, thank you again for your time. I look forward to any questions.
Thank you. Next, please.
Well, thank you, Madam Chair, distinguished members of the committee. My name is Robbie McLuckie, and I'm here today from the Consumer Healthcare Products Association, representing the manufacturers of dietary supplements, over-the-counter drugs, and OTC medical devices. I'd also like to add I'm a lifelong proud Frederick County resident, so thank you, Delegate Kerr, for your service. I'm here today to voice opposition to House Bill 884. Dietary supplements play a vital role in the lives of millions of Americans. Whether it's addressing a specific nutrient deficiency or supporting general health goals, these products provide essential benefits. Unfortunately, House Bill 884's broad and vague language creates significant concerns, particularly with an expansive definition of dietary supplements and weight loss for muscle building. This could be unintentionally restricting access to products that are primarily designed for general health benefits. Another concern is the redundant age verification requirements for home delivery. Currently, verifying age through identification at the point of sale is an effective and necessary practice to prevent minors from purchasing certain products. However, requiring an age ID identification upon delivery for online purchases is unnecessary and burdensome. This added layer of verification would disrupt the convenience of home delivery, especially for adults who may not be available to sign for their products during the standard delivery window of time. It's important to note that similar legislation has been proposed in other states, but it has faced significant challenges. In New York, the only state to have adopted such an age restriction is currently involved in litigation. Even Governor Hochul vetoed similar legislation before signing a modified bill into law, acknowledging its shortcomings. California has also vetoed similar restrictions in the past, recognizing challenges of enforcing a law like this. So in conclusion, while protecting minors' well-being is a priority that we all share, House Bill 884 as currently drafted would do more harm than good. The bill's broad scope could restrict access to many products that are essential to the health and wellness of responsible consumers, and the redundant age verification requirements would disrupt access for individuals who rely on these products to meet their health needs. So thank you for my time to address you today, and I'm happy to take any questions.
Next, please.
Good afternoon, Madam Chair and honorable committee members. I will attempt to be as tall as possible over here. Sarah Price on behalf of the Maryland Retailers Alliance. Our opposition to this legislation is primarily centered around the logistical implications of actually putting it into effect in stores. Restricting access to products, locking them up, or keeping them behind the counter is one of the biggest things that customers complain about in retail these days. I think everybody is aware of the multitude of items that you currently already have to speak with an employee to get access to, and we are trying to limit that long list of products and not move an entire shelf section behind yet another pane of glass. We also have some concerns about the very expansive ways in which diet pills can be defined per this legislation. Our retailers have no idea how these supplements and products are being marketed on social media or in hashtags, and it can be very difficult for every individual retailer to try to make a list of every single product that could possibly be impacted by this. The recommendation that we have made to the sponsor every year that this bill has been introduced is that we would be able to comply if the state created a list of products and if the requirement was to verify age upon purchase. Were that introduced, we would be able to have a much more productive conversation around this, but as the bill stands, we are unfavorable. Thank you.
I'm missing one person, Daniel Fabricant?
That's me.
No, how about Steve, Mr., right? All right, it's okay. It's all right. Good afternoon, sir.
Good afternoon. Thank you. My name is Steve Mister. I'm a lifelong Maryland resident, and I'm also the president of the Council for Responsible Nutrition. CRN is the trade association representing the dietary supplement industry. Many of the products that you see when you walk down that aisle at your CVS or Rite Aid or Walgreens. I want to be sure that we're very clear off the bat what bill we're talking about, because the bill that was described by Delegate Vogel's staff person is not the bill that's in front of you. It was a bill that was introduced last year. It is not 884. As you've heard from the rest of this panel, 884 is a bill that actually places age restrictions on these products. It is not a listing of the products. You've already heard a number of arguments against this, so I'm going to focus on three. The first of all is that this bill is a solution in search of a problem. It is not solving any problem. There's talk that there is an eating disorder problem and that if we restrict these products, if we get them off the shelf, somehow we're going to lower the incidences of eating disorders. We all know that eating disorders are a very complex mental health situation. I don't think the sponsors of this bill can tell you that if this bill went into effect and every one of these products came off the shelf, that 5 years from now we would have any less incidence of eating disorders, because it's not a function of the products. It's a much more complicated mental health concern. In fact, the evidence that they support is correlational, meaning that what they say is, if ice cream sales go up and crime goes up in the summer, well, then the sale of ice cream must be causing an increase in crime. That's a correlation that is mutually affected by the underlying cause of hot weather. So that's what's going on here. When you dig into the data, there's nothing there. We hired an independent researcher 2 years ago, and we told them, go at it. Whatever you find, we'll publish. So don't give us the answer we want, but review all the data, do a literature review, and tell us if there's any evidence that our products cause eating disorders. And there was absolutely no evidence that these products lead to eating disorders. Thank you.
You can pull your chair up because we're going to open it up for questions now, so you can join the rest. Okay? I'm going to open it up for questions now. Are there any questions from the committee? All right, seeing none, thank you very much.
Thank you.
This actually concludes the bill hearing on House Bill 884. Next, we have House Bill 996, Public Health Benefit Consumer Protection Act, Delegate Bandari. Will you, I don't know if you have a panel, or you do not, okay. Go ahead. Good afternoon, Delegate Bandari.
Good afternoon, Madam Chair and distinguished members of this BEST committee. I present HB 996, this Phenibut Consumer Protection Act. This bill is very vital in addressing the public health risks associated with the unregulated sale of use of this substance. And this substance is often marketed as a supplement purported to improve sleep, reduce anxiety, and enhance cognitive performance. However, despite its widespread availability, there are growing concerns regarding its safety, particularly when misused in conjunction with other substances. And the key provision of the bills is mandatory disclosure of factual basis for claims, prevention of adulteration and contamination, and age restriction, restriction on advertising, reporting on adverse health effects. And this bill would help mitigate those health risks associated. And I urge the committee to support the passage of this bill. And I do have Jim Alvey testifying in favor of this bill.
Thank you. Good afternoon. Good to see you.
Will you speak?
Yep. I want to thank the Health and Government Operations Committee, Chair Pena-Melnick, Vice Chair Delegate Cullison, for considering HB 996, providing me an opportunity to speak. My name is Jim Alvey. I'm a resident of Columbia, Maryland. My wife Cindy and I are grateful to Delegate Bandari for sponsoring this bill, and of course Delegate Gazzoni for unwavering support in Howard County. Yes, I am and we are in support of HB 996. However, we do request the committee consider amending the bill to make Phenibut a Schedule I or II substance in Maryland. Why? Because Phenibut took over our son's life and his addiction led to his death. We support HB 996 because it requires a retailer to ensure Phenibut marketing is clear and also protects citizens under the age of 21. But our son died at age 33. We need to protect all Maryland citizens from this drug, not just those under 21. This legislation would align retailer penalties with those of tianeptine, the ones this very committee supported last year, with fines up to $5,000 and 90 days in jail. Again, that is very, very good. But Maryland should go further. Phenibut and tianeptine have no medical value and are highly addictive. They should be Schedule I or II substances. Our son, JT, by all accounts, was an adorable child, grew up to be the son that every mom and dad would be proud of. A student athlete, graduated with honors, accepted into Johns Hopkins School of Business. He started his young career adult blessed with talent and ended up suffering. JT suffered from anxiety all his life. As a young adult, he self-medicated with alcohol. When alcohol led to life problems, he worked to get sober. He achieved that several times, but anxieties and behavioral challenges always returned, threatening jobs, security clearance, and others. So we look for more powerful and untraceable options to relieve his intense stress. He learned to get easily by synthetic drugs online from Russia and China and other countries. But then he found tianeptine and phenibut. I'll jump to my conclusion. Thank you. Then he found tianeptine and phenibut, made in America, available online, and sold at gas stations, vape shops, grocery stores, you name it. They took over his life and led to his death. Just to reconfirm what Delegate Bhandari said, the side effects of phenibut include difficulty breathing, lowered blood pressure, tremors, seizures, irregular heart rate, insomnia, psychosis, and delirium. Those are the side effects. We saw all of those with JT and took him to the ER multiple times before we knew what was causing them. That's because the hospitals always released him once he stabilized without a clue what had caused the symptoms. They had never tested for phenibut. Quitting is also extremely hard because withdrawal causes all the same symptoms. We witnessed deep sadness, anxiety, shakes, hallucinations, and his attempts to quit phenibut. These are the very symptoms that he thought these drugs would help with, but he could not stop taking them because, as he told us, withdrawals from phenibut felt like death. In the end, we believe JT passed January 28, 2022 as a result of seizures so violent they caused damage to his head, face, feet, and torso. He was found alone in his locked room in Days Inn at Cambridge, Maryland. The police report indicated there were phenibut pills and bottles scattered everywhere. But his autopsy report from the Baltimore Medical Examiner did not show traces of phenibut. That's because even the medical examiner does not test for phenibut. In conclusion, for me and Cindy, who's here with me, HB 996 could bring a small sense of comfort knowing JT's death helped to save others. But a maximum $5,000 penalty for selling the drug that led to our son's death is frustrating, to say the least. Again, phenibut has no medical use and a high potential for abuse, the exact definition for controlled substances. Please consider making it a Schedule I or II controlled substance, as Alabama has done, no competition there, and other states are considering right now. No matter what, please vote yes on HB 996. We support it. Thank you for your service to our community and consideration of this testimony.
And thank you again for being here and for sharing your story of your son, okay? Sorry for your loss.
Thank you.
I'm going to open it up for questions now. I don't see any from the committee. It doesn't mean that we didn't listen to you.
Gotcha.
Okay?
Thank you.
You're welcome. This actually concludes the bill hearing on this bill. Thank you very much, which is House Bill 996. Next, we have Delegate Rosenberg,
Thank you.
which is House Bill 729, Public Health Use of Opioid Restitution Fund and Training under the Overdose Response Program. And Delegate Rosenberg, I believe you have NCCA with you. I don't see her. Oh, she's coming. There she goes. Wow, you heard from outside.
Madam Chair and fellow members of the committee, House Bill 729 would conform the permitted uses of the law regarding permitted uses of the opioid restitution fund with the settlement agreements that have been reached throughout the country regarding opioids. We had a head start as a state in addressing this problem because we had the experience of the cigarette restitution fund in creating our model. And time has now, I think, brought us to where we should be consistent, conform with what other states have done, and that is have their the uses of this fund be consistent with what has nationally become seen as the best uses of this money to address the problem, especially after you hear the horrible story that we just heard in terms of the urgency of prevention. And this bill would also explicitly address racial disparities in all aspects of the problem caused by opioids, which still lingers, and the bill would make it a priority and an accepted use to address those problems, which we have yet to resolve. So for all those reasons, I would urge a favorable report on House Bill 729 to continue our work in this area. Thank you.
Thank you, Delegate, for your leadership in this area. You were, instrumental in getting this initially through. And
thank you.
Thank you, Madam Chair, Madam Vice Chair, members of the committee, and CCOT, testifying in support of the bill on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. I would use the word prescient when it comes to Delegate Rosenberg and his leadership in the specific area.
We had done it once before, as I said, so it was no. Thank you.
It was great. And this bill really is to align the state's allowable uses with what's been decided through the settlements and the judgments at the national level. We established it so early, it was prior to the settlements that we said this is what the state can use the funds for. And so we left out some things because we didn't know. So this would just make things a little more flexible and more inclusive in how we can spend the money. There was a drafting error in the bill. There's a bracket that should have been earlier. There was some confusion caused because it looks like we're cutting the allowable uses in half. The truth is we want to take out all of those allowable uses, just move the bracket up a few lines, and have the language that ties everything to the national settlement. The overall, this is how the money should be spent. So we apologize for not catching that earlier. But I think that you're going to hear from some folks who read the bill correctly, which was not the intent of the bill. So I think we have an amendment that's going to, everybody agrees to fix that. We absolutely want to make sure that we are focusing, adding in the bill the focus on racial disparities. While we've seen recent data showing a decrease in overdose deaths, we are still seeing that disparity among races. And so we absolutely have to make sure we are focused on those kinds of strategies and projects and programs that help address that. And then finally, there's also a piece in there about the overdose response trainings, separate from the opioid restitution fund. The trainings that happen around the use of naloxone. And what we want to add in there is some emerging best practices around compassionate overdose response, which is a focus on breathing techniques, agitation, and smaller doses of naloxone. There's just so much more that we know about what it takes to get somebody out of an overdose in a way that doesn't immediately make them sick or agitated or in a bad place. So with those changes in the bill, we ask for a favorable report.
All right, thank you so much. I'm going to open it up for questions now. Are there any questions for the sponsor and his panelists? Okay, seeing none, thank you so much. Really appreciate you. We have next favorable with amendment panel, Bill George and Carrington Anderson.
Good afternoon, Chair, Vice Chair, members of the committee. Bill George with the Maryland Municipal League here today supporting House Bill 729 with amendment, the amendment being that with the sponsor panel mentioned. In 2021 and into 2022, MML and MACO negotiated a state subdivision agreement with the Attorney General's office that laid out the framework for how the funds from opioid settlements would be, that come into Maryland are dispersed between the state and local governments. So counties and municipalities receive direct funding from the settlements, but also money from the ORF. And so that's where our interest in this bill comes in. The intent, I think, is fantastic. We've found that as the settlements have moved on, the eligible uses are actually more expansive than they are in the code. And so this to us, provides more flexibility on how these funds can be spent while still addressing the problems that they are intended to. So there are certainly still guardrails in place through the eligible uses that are stipulated in the settlement agreements. So this isn't just going into general fund for a rainy day use or anything like that. They are going towards remediation and treatment and that sort of thing. So happy to support the bill with the sponsor amendment. Thank you.
Thank you. Next, please.
Thank you, Madam Chair and members of the committee. My name is Carrington Anderson with the Maryland Association of Counties, speaking in support with amendments on House Bill 729. I want to thank the sponsor for the bill. We strongly support the intent of the legislation. I think my colleague from MML outlined that very well, and the sponsor panel as well, to have the language referencing the settlement agreements. We think it's wise policy, and this bill will provide local governments with greater flexibility to combat the opioid crisis. Our amendment aligns with both MML and the sponsor, just striking the allowable uses to align with the settlement agreements. Happy to answer any questions, and for these reasons, we urge a favorable amendments report. Thank you.
Any questions for this panel? Seeing none, thank you so much for being with us today. We appreciate it. This actually concludes the bill hearing on House Bill 729, and we're going to go on to House Bill 783, and I would like to call as a panel Bill Kress, Lou Bartolo. Okay. Okay, and I'm going to give the testimony from here so it's less disruptive. So good afternoon, Vice Chair, actually Chair. Chair and members of the committee. I am pleased to present to you House Bill 783. House Bill 783 expands beyond the implicit bias training that we passed in this body that require implicit bias training for all healthcare providers. And it requires that the healthcare providers receive education on structural racism. Which includes understanding how policies, institutional practices, and systemic barriers contribute to health disparities. We hear that in this committee every day. We see the data of how different communities are affected and the disparities. While implicit bias training helps providers recognize their own unconscious biases, this bill takes a broader approach by addressing the root causes of the inequities, such as disparities in healthcare access, differential treatment in medical decision-making, and the historical and policy-driven factors that create barriers for marginalized populations. The bill ensures that providers not only acknowledge bias, but also develop actionable strategy to mitigate systemic inequity in patient care. So you might ask, how will this be done? Well, the bill will require this training, and you will hear from the American Nurses Association that they have received a $1.2 million in funding that was broken in 10 grants, and Maryland is going to get $100,000. So there's no fiscal node, although the bill right now states so, to develop a system, a training class, right, with the University of Maryland that the healthcare professionals can take, and it will be at no cost, okay, to them. You will also, if you read the bill, you see that the bill requires self-attestation at the time when you renew your license, right? And when you first get your license and when you renew it. There's different amendments that have been proposed, which I would accept them. I think they're friendly. One of them actually will allow the bill, these classes, people that take it, to earn continuing education credits, right? We all know that we have to take continuing education credits for our professions. This will allow these classes, the boards, if they want to, not require, may actually adopt regulations to allow continuing education credits as well. One of the definitions, the Department of Health supported it with amendments. I'm fine with the amendments that they suggested as well. The bill belongs to the committee, so if the committee feels that they're appropriate, I'm fine with those amendments as well. I think that This is a bill that is not burdensome. It's a one-time requirement only. You don't have to keep taking it over and over again. It's just one time. And it is the right thing to do. When we listen to these bills here, we see the disparities with different groups, right? When we look at infant mortality, we see those numbers and how they affect marginalized community. When we look at maternal mortality, we see those numbers, how Black women are dying at a rate 4 times higher than white women, right? When we look at who goes to the ER, we see the numbers. When we look at the number of people that have chronic diseases like kidney disease, hypertension, we see who is the community that is being affected the most. The numbers don't lie. And what can we do? This is something with this environment and the fiscal note that we have, this is something that we can do that will help people have access to care and will help our professionals understand their patients better. I asked that you consider it and that you give this bill, House Bill 783, a favorable report. Next, who would like to go next?
Thank you, Madam Chair Penna-Melnick, and thank you also, Vice Chair Cullison. And also, Chair Penna-Melnick, thank you for sponsoring our bills of 783. I am Lou Bartolo. I am the president of the Maryland Nurses Association. Today, I support House Bill 783, as this bill will actually help to advance healthcare professionals by improving the care that they provide to our patients here in Maryland, because we are a diverse state of Marylanders. It will give our patients, and it will allow our healthcare professionals to really understand the differences between implicit bias and then also the differences between racism and structural racism. This bill will also help to improve racial and ethnic disparities throughout Maryland while providing the higher standard of care that we can help to increase our outcomes of our patients. The Maryland Nurses Association actually partnered with the University of Maryland School of Nursing to develop a training on health for the healthcare providers, not just nursing, but healthcare providers, on structural racism. Maryland Nurses Association is actually considering to have the continuing education credits attached to the actual training for nurses, because that has been a question that a lot of the nurses and a lot of the members have asked for. So we're happy to provide that service to them. Now, as far as we've been in talks also with other healthcare professions, and they would like to do the same, and we are leaving that up to those professions if they would like to continue with continuing education credits attached to the training as well. So with that, we actually look for a favorable report. Thank you very much.
Thank you. Next, please.
Thank you, Madam Chair, members of the committee. My name is Bill Kress. I'm here today on behalf of the Maryland Nurses Association. Madam Chair, thank you for sponsorship of this bill. Thank you for bringing together the stakeholders and having dialogue and working out some of the minor issues and amendments. I think the bill is in a good spot with the amendments. I was going to go into some detail about healthcare disparities, but I think you did it so eloquently. This committee knows it very well. In order to understand the root causes of these problems, you have to at least appreciate the nature of structural racism and how it's impacted the healthcare system in Maryland, historically and going forward. So this is a small measure to give that education to healthcare providers. It's the first step in having a greater understanding how to address the larger issues. I think the program that the University of Maryland School of Nursing is putting together will be up and running within a year, and it will be free and available to all healthcare providers. So fortunately, there won't be any fiscal impact there. With that, I'll end my testimony, and thank you again, Madam Chair.
My pleasure. Are there any questions for this panel? Go ahead. Vice Chair Collison.
Thank you, Madam Chair. And for whoever is the best person to answer. So to me, this is an absolute necessary program. So I'm really happy to see it here. The question is, do we think ultimately down the line this could be, it seems to fit with the CEU requirements really well. And I guess I understand the fact that it's not mandated. But could we see it ultimately working towards that piece? Because we want to say to folks who are being licensed or renewing their license and who hasn't had it, we want to say to them it's really important. A way to make it valuable to them is to make sure that they get the CEUs. So is that in the works? Is there?
Yeah, that's actually one of the amendments, I believe, and certainly the nurses would support it. I've had conversations with MedChi. They raised it in their testimony. They thought that might be a good idea as well. Well, I think why they said they don't like mandated continuing education credits, this would be appropriate in this case. Not to speak for them, but it's in their testimony.
Thank you.
Thank you.
Thank you. Seeing no other question, thank you so much for your testimony. Really appreciate it.
Thank you.
We do have, thank you, favorable with amendment, Aliyah Horton and Andrea Mansfield.
Good afternoon. My name is Aliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. We're the professional society for pharmacists, pharmacy technicians, and student pharmacists. HB 783 is in alignment with the work that we've been doing within our association in the practice of pharmacy and in the implementation of the implicit bias training as we were going through making sure that we had the training available for our members. We did run into barriers where the current statute references the Accreditation Council for Continuing Medical Education, and that does not cover pharmacists' continuing education. They have to go through several steps to get that training approved by the Board of Pharmacy and other boards across the country. And so we have proposed an amendment that would just add at the end. Another option is the Accreditation Council for Pharmacy Education, which is the equivalent of, I don't know how they pronounce it, ACME. It's not in my purview for that one. And so we want to make sure that happens. There is a section for pharmacy license renewal under the National Association of Boards of Pharmacy where there's an other category. So we don't necessarily need it to specifically talk about continuing education units, just that this accreditation body is referenced in the statute, and that would work for us. And appreciate the consideration. I understand the chair was amenable to that amendment, and we appreciate that.
Absolutely.
Thank you.
You're welcome. Great. Next, please.
Yep. Thank you, Madam Chair, members of the committee. Andrea Mansfield, representing the licensed clinical professional counselors of Maryland. I'm here supporting this bill with amendments. Yes, and thank you, Madam Chair, for referencing amendments in your comments. We really appreciate that. Licensed clinical professional counselors fully supports these training requirements. However, they were also interested in seeking continuing education credits for taking this. So actually in the written statement that you have in front of you, we're actually suggesting that language be amended to allow the board, that a board may adopt regulations to provide continuing education credit for the completion of implicit bias and structural racism training. And I know we're happy, I think you have Ms. Horton has a little bit different amendments, but we're happy to work with all parties to make sure these are workable for all of the boards. That we urge a favorable report with amendments.
Thank you very much. And I definitely accept them, right? It will go to subcommittee. The subcommittee, you can discuss it there, but I'm fine with it.
Great.
Any questions? Seeing none, thank you so much for being with us today. And this actually concludes the real hearing on House Bill 783. Next, we have House Bill 743, Delegate Bagnall, Public Health Healthcare Quality Fund for Community-Based Behavioral Health Program Establishment. You do have a panel, which is Nicole Granner. Will you come up, please? Daniel Shattuck and Carrington Anderson. Will you be so kind and come up? Thank you. We're rolling along. We're making progress.
Good
afternoon, Madam Chair, members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here to present House Bill 743, Healthcare Quality Fund for Community-Based Behavioral Health Programs Established. You have my written testimony, so I will summarize. Maryland has a robust behavioral health system that serves our constituents well with a dedicated workforce of providers. However, even the best systems of care have providers that fall out of compliance with state law. In those instances, fines may be levied against providers as punishment for violating the law. These fines are known legally as civil monetary penalties, or CMPs. Funds attained from these penalties are, under current law, allocated to the general fund. Now, the purpose of the CMP is to encourage corrective behavior and bring providers back into compliance. While the fine itself is incentive to prevent our providers from falling out of compliance with the law, there is an opportunity to use those funds proactively to ensure compliance, bolster our behavioral health system, and improve health outcomes. House Bill 743 provides a solution by creating a special fund to improve behavioral health programs and assigning CMPs to that fund instead of the general fund. House Bill 743 ensures a mechanism for reinvestment into our behavioral health system by directing CMPs collected from behavioral health providers into a new health care quality fund. This fund will be tightly focused on training, grant awards, and demonstrations to improve behavioral health services, which will move us closer to a higher quality of care. Moreover, House Bill 743 provides for innovation by funding programs that test and refine new strategies to improve behavioral health outcomes, making sure that Maryland leads in the development of community-centered care models. The Behavioral Health Administration already provides critical training and technical assistance to behavioral health providers, including programs on mental health, substance use disorder treatment, and trauma-informed care. Similarly, nonprofit organizations like the Maryland Behavioral Health Coalition are actively working to improve service quality through training and quality improvement initiatives, such as the Mental Health First Aid Maryland. These efforts often face funding limitations, which House Bill 743 seeks to address by creating this new funding source. And we have requested a couple of amendments to the bill at the request of the Department of Health and our advocates for the bill, and we believe these will also address the fiscal note. Those amendments were sent to the members of the committee in advance of the hearing, and they are consensus amendments. Now, by establishing a dedicated fund for community-based behavioral health programs from existing civil penalties, we have the ability to reinvest that money in improved health outcomes and quality of care for Marylanders. With that, I respectfully request a favorable report on House Bill 743 and turn it over to my esteemed panel.
Okay, who would like to go next?
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Maryland Psychological Association in support of the bill with the amendments. I just want to echo the delegate's great description of the bill. I think the key here is reinvesting monies that have already been dedicated through whatever mechanism, but to these behavioral health and substance abuse treatment providers. And I think keeping the money in the system is key. We're always looking for ways to fund new trainings and innovations, and if we can harness these funds and put them to good use, I think this bill goes a long way. And it's also not recreating a wheel. This is a system that is not uncommon in the state, where you take civil monetary penalty monies and put them back into the hands of the providers that are doing the good work with the money to begin with. So with that, we are just strong, favorable report.
Thank you. Next, please.
Thank you, Madam Chair and members of the committee. My name is Carrington Anderson with the Maryland Association of Counties in support of House Bill 743. Want to thank the sponsor for the bill and seeing the need for this, and did a great job explaining the bill. It provides dedicated funding for behavioral health care programs. It really just provides more tools in the toolbox by adding resources for training, grants, and projects, and just really think that this bill is important and there's a strong need for this, and again, want to thank the sponsor. So it's for these reasons, MACO would suggest a favorable report on House Bill 743.
Good afternoon, Chair. Good afternoon, Chair Peña-Melnick, Vice Chair Cullison, and members of the committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland, or CBH. As the leading voice for community-based providers in Maryland, CBH represents 87 organizations that serve the majority of individuals accessing care through the state's public behavioral health system. These providers deliver essential mental health and substance use services, including outpatient and residential treatment, case management, and crisis intervention. As you are aware, our sector is grappling with severe workforce shortages. Providers are struggling to recruit and retain qualified staff, which results in service delays, increased staff loads, and diminished capacity to meet the growing need. House Bill 743 offers targeted, proactive solutions by ensuring that civil monetary penalties imposed on behavioral health providers are reinvested into workforce development and quality improvement initiatives. This reinvestment will directly support training programs, recruitment efforts, and staff retention, all aimed at building and sustaining a stronger behavioral health workforce, allowing providers to enhance the quality of services they provide to vulnerable Marylanders. Importantly, the bill ensures CMP funds are used transparently and effectively, targeting workforce development and compliance with state regulations while avoiding excessive financial burdens on providers. By capping fines and dedicating the funds to a healthcare quality fund, this legislation fosters continuous improvement within the behavioral health system. House Bill 743 will help strengthen Maryland's behavioral health workforce, improve service delivery, and increase access to care. We believe this approach is essential to addressing the workforce crisis and improving patient outcomes. We respectfully urge a favorable report. Thank you.
We're going to open it up for questions now. Delegate Hill.
Thank you, and thank you for this great idea. The fiscal note says that MDH advises it will need to hire 3 full-time employees. Would the fund, or does the bill allow for the funds to also be used to pay for those, to pay for its own operations as well as the behavioral health things?
Thank you. We're working with the Department of Health. We think that it was the inadvertent inclusion of the Office of Healthcare Quality that actually triggered that that fiscal impact. So we're working with the Department of Health. One of the amendments is to take the OHCQ out of the bill, and we're working with the department to determine if that will effectively remove the fiscal impact.
Okay, great. And do you have any idea? I mean, I hope the fines go down every year, but what kind of money are we talking about here?
Yeah, we set it up to be very similar to what's being done in the assisted living facilities, and that fund averages about $78,000 currently.
And in the behavioral health, what kind of funds, what kind of fines are we seeing every year?
The truth is, we haven't been able to figure out where those fines are and where they're coming from. This is really done proactively with regard to what's happening with the 106309 COMAR regulation revisions. So we're trying to establish this fund ahead of time so that when those funds start coming in, that we have a dedicated place to put those in and really reinvest those back into our workforce.
So fines that are going out now are not.
I think they're just going into the general fund.
But you don't know how much that, the Office of Healthcare Quality can't give you an idea of, on average, we find 5 practitioners and we get. Yeah.
I haven't been able to get that information, but I'll request it and share it with you.
Thank you.
To the best of our ability.
Okay. Any other questions? Seeing none, thank you so much. We really appreciate you. And this actually concludes the bill hearing on House Bill 743. For the committee, we're doing great. Let's move on to House Bill, Delegate Bagnall, you can stay right there.
You want me to stay right here?
Yes. Let's go to House Bill 737.
Okay.
Okay. And I would like, do you have a panel? You have
I do.
John Friastro, Deanna Lickens, and Lisa Lowe are in your panel. Is that right?
That's correct.
Will you please come up? And you can get started, Delegate.
All right, thank you very much.
My pleasure.
Once again, good afternoon, Madam Chair, members of the Health and Government Operations Committee. For the record, I continue to be Delegate Heather Bagnall from District 33C, Anne Arundel County, here in strong support of House Bill 737, Non-Opioid Advance Directive. You have my written testimony, so I will summarize. This committee is keenly aware of the impacts of opioid prescription and misuse. According to the American Medical Association, as many as 19% of people who take prescription opioids for pain management may develop an addiction. It is very important that individuals have the autonomy to make informed decisions about their care, particularly when it comes to the use of opioids. Often they are the default despite patient hesitation, and it can be very difficult to advocate for an alternative. In many treatment plans, opioids are not the only option available for pain management. Those who would rather not use opioids for pain management often have a variety of choices to consider. Now, House Bill 737 protects patient choice by allowing an individual to make an advance directive to refuse opioid medications in favor of non-opioid pain management if the option is available. This option will allow individuals to plan their treatment around their preference for opioid pain management. If a patient is unable to articulate their desire to consider non-opioid options for treatment before an opioid is considered, an advance directive will allow them to alert providers of that preference. With this option, patients will be empowered to make choices in line with their personal values and their preferences. Now, there are some outstanding concerns we've received on the bill, and I have requested amendments to address concerns from MedChi and from hospice stakeholders who have provided testimony for the bill. Those amendments were sent to the committee in advance of this hearing. The bill as drafted created a separate advance directive for non-opioid pain management. The amendment I requested folds the non-opioid option for pain relief in with the existing behavioral health advance directive to reduce the concerns about confusion with their being separate directives. Providers have also raised concerns about their ability to administer opioid pain medication in an emergency when it is deemed medically necessary. And the amendment I requested includes a clause stating that the providers may still administer opioids in emergency cases. With these amendments, House Bill 737 aligns with Maryland's efforts to combat the opioid crisis by giving individuals a streamlined way to control their health care choices and by promoting equally safe, non-addictive pain relief alternatives to opioids. It is fiscally neutral, and with that, I respectfully ask for a favorable report on House Bill 737.
Who do you want to go next?
Sure. Thank you, Madam Chair.
My pleasure.
For the record, my name is John Fiastro, here on behalf of Helion. Just want to hit on a few points that the delegate made. There is some questions about a standalone document. As mentioned, the amendment that you will have folds it into the existing 5603 of the Health General article, the existing advance directive that is statutory. There are questions about limiting a practitioner's ability to treat pain. Well, the amendment actually offers practitioners the ability to provide patients with opioids if it is deemed medically necessary and in the best interest of the patient. Finally, in regards to any potential liabilities that might be outstanding if a patient has adopted a non-opioid choice in their advance directive for to protect those practitioners and alleviate concerns regarding liability, you will see that there is reference to 5607 of the Health General article and 5609 of the Health General article that says that the practitioner will be shielded from criminal prosecution and civil liability. So that should answer all the outstanding concerns. Now look, the Health Care Decisions Act was passed in 1993, over 30 years ago. And at the time, the state and the country was not suffering from the opioid epidemic as it is today. The Health Care Decisions Act should be revised with regularity. This is an appropriate revision that is reflective of the situation that the state finds itself in. So for that reason, we ask this committee to move favorable with the amendment as provided by the sponsor. We would like to thank the sponsor for carrying this bill as well. So I'm sorry I didn't do the customary thank you for your leadership on this, Delegate Bagnall. Thank you.
She deserves those flowers. She works hard. Next, please.
Hi, thank you, Madam Chair, members of the committee. I also would like to thank the sponsor for taking on this important issue. I'm Dina Likens with Helion. We are the largest over-the-counter medicine company in the world. We make Advil and Excedrin, and we've been part of kind of the pain management world for decades. And we came across this bill in a number of other states, and it's now enacted in 10 different states. We look at it as just an opportunity to improve communications between patients and their providers. In many cases, a person who has an addiction history may have a level of discomfort in kind of talking about that with someone, and so this is just meant to kind of ease those communications. I also was reminded today, my mother one time broke her shoulder and was given prescribed opioids, and she took them home, but then she refused to take them. And so she went without pain medication because she was too scared to take the opioid. She was afraid she would be addicted. But then she had offered none. I mean, she probably took some Advil. But there's many cases where this just is a mechanism for communication on an issue that is very important. And so we appreciate your time and consideration of this bill. Thank you.
And thank you for sharing your story, and thank you for being here. We appreciate it and working with a delegate. I'm going to open it up for questions now from the committee. Are there any questions, Delegate Kipke?
Thank you, Madam Chairman.
You're welcome.
I just want to thank the lady for making Advil.
You're very welcome.
Thank you.
You're welcome. Delegate Hutchinson, you're going to thank her for the other one? No, just kidding.
Thank you, Madam Chair. Whoever's the best. But so in reading the MedChi opposition letter, and then you're saying that you have amended it that a physician can still administer opioids if it's medically necessary. Is that how I heard you say that?
That's correct. So we didn't have that language when we drafted the bill, but we have requested the amendments.
So then with that, where's the teeth in the directive? Because when would a physician administer opioids when it wasn't medically necessary?
You want to speak
Well,
to that?
I can say that there are times where people have different levels of pain that they're wanting to accept, and so that's what it leads up to the individual. So, my 8 might be somebody else's 4, and so it could be, there are different reasons why opioids, but opioids are overprescribed in the nation, and that is part of this. So this is, again, it's just the directive can be revoked at any time. If I think I don't want them and then I get there and it feels super painful, I can say I don't want it anymore. This is just so that the doctor knows the patient's preference.
So the patient would have to say, I revoke it before the physician would administer the opioids?
Not according to the medical necessity. That's just saying that it's not written in stone. You can decide to change your mind about a medical directive.
Great. Thank you very much. Thank you, Madam Chair.
You're welcome. Any other questions? Seeing none, thank you so much.
Thank you, Madam Chair.
You're welcome. We do have Lisa Lowe. Will you be so kind and bring her up? Thank you so much. Hi, Lisa. Hi, Lisa. How are you? Can you hear me? All right. Nice to see you. Haven't seen you this session. Go ahead and give us your testimony. You can get started. You can get started.
I can?
Yes.
Oh, I'm still hearing the last person talk.
Because you have to turn off your system.
Yeah, I turned that off.
Okay, wonderful.
Okay, thank you.
You're welcome.
I just wanted to say, to pass this bill favorably. It is still, as Delegate Bagnall pointed out, hugely concerning that non-opioid alternatives for pain management and for the treatment of opioid addiction, with study after study after study supporting their efficacy, have not made it into mainstream healthcare as they have in other countries, Canada, Europe, South and Central America. And this very committee has passed bills acknowledging the efficacy of non-opioid alternatives for pain relief, like the bills you passed regarding cannabis and kratom, which still haven't made it into the lexicon of our public health care options. So it seems that the pharmaceutical industry still controls our health systems. People should not have to wake up in a hospital to find that they are now addicted to opioids. They must be able to assess their own risk, make their own decisions, and give their own permissions. Please pass this bill favorably. We have lost too many of our loved ones to opioids, and this just puts control in the hands of patients and consumers where it should be. Thank you.
Thank you for your testimony, Lisa, and thank you for the years of advocating on these topics, okay? We appreciate you. I'm going to open it up for questions now. And are there any questions? I don't see any, but thank you so much, okay? Committee's going to work on it. Have a wonderful day. Will you please, there is a Dr. Rachel Jordan here. Will you please come up?
Good afternoon.
Hi, how are you?
I'm well, thank you for the opportunity to testify today. I'm Dr. Rachel Jordan, here in a different capacity. I usually sit for the Board of Nursing, but I'm actually sitting as the Director of Advocacy and Legislative Affairs for Hospice of the Chesapeake. We have a 45-year history of providing compassionate care for those who are facing illness and loss. So not just those enrolled in hospice, but for palliative care patients. We are the region's largest independently owned not-for-profit hospice, and we feel compelled to express our concerns regarding House Bill 737. And I did have the opportunity to hear some of the amendments, so we are encouraged. But while we understand the notable intentions behind this bill, we believe the implementation could have unintended consequences that may hinder the patient-centered approach integral to quality end-of-life care. And rather than empowering patients, this bill could potentially limit access to essential symptom management, leading to unnecessary distress and suffering at the end of life. It is undeniable that we are going through an opioid crisis. However, hospice and palliative care providers are experienced at attending to patients at the end of life while considering their unique medical and psychiatric backgrounds, including a history of opioid allergy, intolerance, or addiction. The judicious use of opioids in hospice care is carefully customized to each patient's individual requirement, ensuring a balance between the benefits and the risk through ongoing clinical assessment. Opioids play a crucial role in alleviating not only pain, but other distressing symptoms, such as shortness of breath, consequently enhancing the quality of life and addressing symptom burden for someone who is going through chronic life-limiting illness or end-of-life care. This bill targets a specific drug class, potentially fueling misinformation about unwarranted fears regarding the use of opioids in the end of life, and it detracts from essential conversations about the patient's goals of care and focuses on hypothetical scenarios that may or may not arise towards the end of life. So introducing an additional advanced directive solely for opioids appears redundant, so I'm happy to hear that this will be rolled into what is already established. And also the Maryland Order for Life-Sustaining a Treatment, I believe on option 8, gives a provider and a patient the option to have a discussion and document their specific wishes. So given these considerations, we firmly believe that the enactment of House Bill 737 could have detrimental effects on the individuals receiving end-of-life care, and therefore we respectfully urge an unfavorable report. Thank you.
Right, thank you. Vice Chair Collison.
Thank you, Madam Chair, and thank you for your testimony. So I heard a strong opposition, but then I heard some, kind of, we're open, we were glad to hear some of the amendments. So do you think that there is a place that we could reach agreement on the bill with some work?
I definitely think so, with some work. one of the things that we grapple with and we fight with in the realm of hospice is re-educating the community on their fears and misinformation about opioids. And I can tell you as a hospice provider, the first thing a patient will say or a family will say is, you're just going to give my loved one morphine and let them die. And that is not the case. Oftentimes, we don't even prescribe it until a patient actually needs it, and morphine is not the only drug that we use. So something like this may cause our patients to feel that they should fear opioids, and it should be a goals of care conversation that happens at the time that the need is identified. And that need may change, and that's why we've heard some of these amendments.
Okay. All right. Thank you very much.
You're welcome.
Thank you, Madam Chair.
You're welcome. I don't see any other questions, but I will, oh, I'm sorry. Delegate Shaleka, I didn't see it. I apologize.
I was late. I was hoping you were jumping in to ask my question. Thank you. I'm glad to hear that you're willing to work with the sponsor to bring, a good solution for all Marylanders. Now, it's my understanding that a patient in hospice or their power of attorney, their medical power of attorney, is able to change that.
Yes, so it depends on how the advance directive is written. We have some patients who present an advance directive and they can say, under no circumstances are my wishes to be overridden. It depends on how they enact it, when it becomes effective, if two physicians need to certify that the patient is not capable of making their decisions before it can go into effect. But absolutely, having a goals of care conversation is very fluid and it's very situational. So a delegated person or the person.
The patient themselves.
Or the patient, correct.
The patient could override their advance directive verbally and say, I would like some opioids to ease my
Absolutely.
pain. Okay,
Yeah.
Thank you.
Okay. All right, if you can meet with the delegate and try to see if you can work it out, okay?
Yes.
Thank you very much.
Thank you.
Appreciate it. So this actually concludes the bill hearing on House Bill 737. Next, we're going to the last bill of the day, which is Delegate Rosenberg, House Bill 870, Tobacco Product Manufacturers Escrow Act alterations. Delegate Rosenberg, you have, I believe, Laura Hale, Eric Galley, and Arabin. I don't know, is the Office of the Attorney General here?
They are.
Okay. If you can come up and join the delegate, please. And you can get started.
Thank you, Madam Chair.
My pleasure.
Earlier, we've discussed or made reference to the Cigarette Restitution Fund as the predecessor to the opioid restitution fund, and this bill deals with that fund. The settlement agreements with the national manufacturers that Maryland entered into provided that a smaller manufacturer could take a different route and not make payments that would then be made available to the restitution fund. This bill would change that in Maryland, and for that reason has a fiscal note, a positive fiscal note of $933,000 starting with the FY27 fiscal year. I don't think we've seen a bill that comes close to this because the smaller manufacturers whose product is as dangerous as those of the big manufacturers, but is not sold in the same, significant amounts, there would be revenue going to the restitution fund, as is the case for all other manufacturers, principally, or the bigger manufacturers. All this is permitted. The current system is permitted under the settlement agreements. But what this bill would do is require that the smaller manufacturers, in terms of the number of cigarettes sold, that they make a contribution or a payment to the restitution fund based on the terms of the settlement agreement, and that the fiscal note estimates that that would be in the neighborhood of 900 plus 933,000 starting in the fiscal year 27. That's what this bill would do. That money would have a significant beneficial effect on our efforts to prevent children from starting to smoke in the first place, children or teenagers, to deal with the problems caused by cigarettes and public sale of cigarettes. And that's what the bill would do. It is, I think, time for us to make this change and would urge a favorable report.
Sure, I will. Thank you, Madam Chair, Madam Vice Chair, and thank you so much to our wonderful bill sponsor. My name is Laura Hale. I'm the Director of Government Relations with the American Heart Association, and we offer our strong support. Tobacco remains the #1 cause of preventable death and disease in the United States, and we see this bill as another step towards continuing to decrease tobacco use in the state. These non-participating manufacturers are still selling products that are addicting our communities and killing our children at the end of the day. And so we really want to make sure that this is a level playing field, that we are having investments, that the state can begin to pull back some of the money that we're losing in healthcare, and to invest that money in tobacco control that you all have done such amazing work on. And in a year where I know budget considerations are difficult, this is an opportunity for us to continue to make advancements for public health with nearly $1 million. We know that helping smokers to never start. We will stop the cycle that allows these non-participating manufacturers to use what's currently in place, that frankly they're lowering their costs of their cigarettes. And so we're really hoping that this will help with raising the cost of some of the cheapest cigarettes in the market, which these products are sold, and to help smokers never start and to invest that in quitting. So the American Heart Association urges a favorable report. Thank you.
Thank you, Madam Chair. Eric Galley, also here on behalf of the American Heart Association. And I am an old man, and I was here when Delegate Rosenberg, who's a much younger man, authored the Cigarette Restitution Fund. And just to answer some of the questions that came up last year in the hearing about why treat these companies one way and then treat them another way in other companies. 25 years ago, it made a lot of sense to do what we did 25 years ago because we had companies that were specifically bad actors and had done very bad things for many decades, and it made a lot of sense to make them pay up in a way that was different than other tobacco companies. But now we essentially have a whole bunch of tobacco companies that are selling pretty much the same cigarette product to everybody. It kills about 1/3 of the people who use the product as directed, and there's not that much difference. So it just makes sense, although we're not going to be treating the non-participating manufacturers exactly the same as those in the agreement. We're moving it a little closer, and it only makes sense because things are different than they were 25 years ago. I was also put on here to remind people, in case we forgot, that the fiscal note is $933,000 positive. And I apologize to you, Madam Chair. A few weeks ago when we met, I had thought that it was going to be $600,000. So I'm pleased to have been off by 50% on that. Smarter people have determined that. But that's the question that came up the most last year, is why make this change? And the answer is we're 25 years out now and things are a little different, and it's time to treat these folks a little bit more like we treat the original manufacturers. Thank you very much, and we urge a favorable report.
Next, please.
Madam Chair, thank you for allowing me the opportunity to speak today, and thank you, Delegate Rosenberg, for sponsoring this important bill. My name is Arvind Muthukrishnan. I'm an Assistant Attorney General in the Tobacco Enforcement Unit at the Office of the Attorney General, and we urge a favorable report on HB 870. House Bill 870 will bring fairness to Maryland's cigarette market by requiring all cigarette manufacturers to compensate the state for the cost of tobacco-related disease. In 1998, Maryland entered into the landmark Tobacco Master Settlement Agreement, or MSA. Cigarette manufacturers who joined the MSA are called participating manufacturers, and they pay the states billions of dollars each year in compensation for past and future harms caused by cigarettes. Over the past 25 years, Maryland has received over $3.6 billion in MSA payments to the Cigarette Restitution Fund, which helps fund tobacco cessation programs, cancer research, and Medicaid costs. In contrast, manufacturers which did not join the MSA, called non-participating manufacturers or NPMs, do not make MSA payments to the state. The General Assembly attempted to level the playing field in 1999, requiring NPMs to make corresponding deposits into an escrow fund each year. These deposits were intended to neutralize the cost advantages NPMs have by virtue of not signing the MSA. However, the Escrow Act did not fully achieve that goal. NPMs retain ownership of the escrow accounts, collect interest earned on the deposits, and are entitled to a return of the funds after 25 years. NPMs can then use those funds to defray their costs and undercut the prices offered by participating manufacturers. NPM sales have increased significantly over the past few years, and as NPMs start receiving back the funds currently held in escrow, we can expect those sales to grow. This increases the cost to the state to take enforcement actions with respect to those NPMs, and critically, this could put the state's MSA payments at jeopardy. HB 870 will help fulfill the General Assembly's original intent by requiring NPMs to pay an equity fee to the state, potentially raising $933,000 in FY27, which can be directed to the Cigarette Restitution Fund rather than into savings accounts controlled by the NPMs. Instead, thus, HB 870 brings fairness to Maryland taxpayers. Thank you. I'm happy to answer any questions, and I urge a favorable report.
Thank you. Delegate Kaiser, followed by Johnson, followed by Olston.
Thank you. Thank you, Madam Chair. My question, I'm not sure if this is for the sponsor or Mr. Galley. In describing this and describing these other companies, the NPMs, can you remind me, was the purpose of the original restitution fund because of the quality of the product or because of the lies of the industry prior to 25 years ago?
Well, I think it was both. I mean, that would be in terms of the action brought by the attorneys general against the companies. I'm sure that both of those reasons were cited.
Okay, thank you.
I have Delegate Johnson.
Thank you, Madam Chair,
Welcome.
and thank you for the bill. But I was under the impression that the reason the cigarette manufacturers had to pay the Cigarette Restitution Fund was because they were bad actors and they did deceive the public and cause harm. And these NPMs came along afterwards and were not part of that. There were notifications on the cigarette packages that it would cause harm. And so the state said, okay, you put this money in an account for 25 years. If you don't become a bad actor, then you get that money back each year, and they got interest on that money. So now we're telling them, even though you weren't bad actors, because, by the way, they are taxpayers too, that we're going to change the rules, and now we're going to take the money. You don't get that back. Is that what I'm understanding?
If I'm
Well, one other facet of the lawsuit that was very important was to get reimbursed for Medicaid expenses. It was a major part of the lawsuit. And again, we're at a point now where they're all selling the same product and they're all causing the same amount of Medicaid expenses in the future. So it just makes sense to recover from them similarly to the way we do the original companies. There's no question that 25 years ago, a piece of it was to punish those bad actors. But most of the lawsuit was about recovering Medicaid money.
Madam Chair, but weren't these companies, these NPMs, told that if they put this money into an account for 25 years and did not become a bad actor, that they would get that money?
Well, but they're still selling a product that's causing all of the Medicaid costs and is killing about a third of the people who use them when used as directed.
Then why didn't we make them pay into the restitution fund to begin with?
Well, because they didn't agree to, they're non-participating manufacturers, they wouldn't agree to it.
All right, thank you, Madam Chair.
I have Delegate Olston, followed by Morgan, followed by Chisholm, followed by Martinez, followed by Taveras.
Thank you, Madam Chair, and thank you, Delegate Johnson. That was a lot of my question. So I will follow up. One, it would be helpful if you could get us a copy of the settlement agreement so that we could all see it for ourselves to see what the actual terms were, because it sounds an awful lot like we're changing the terms after 25 years. Two, you mentioned that people are still selling these products. Is there a defect in the current make of the product, or does the product function as it's designed to function?
Hi. Thank you, Delegate. If I could take this question. With respect to the master settlement agreement, this is a contract that is over 150 pages long and includes a lot of provisions which do not affect the non-participating manufacturers. Mainly among them are a host of advertising restrictions, as well as requirements that they hand over their documents going back decades, and to fund the Legacy Foundation, which is now the Truth Initiative. There were a lot of provisions that are, and impositions on the participating manufacturers because of their past misconduct. With regards to the non-participating manufacturers, this is only going to affect their future conduct and their payments going forward. So there's no changing of the deal. If they've deposited funds, those funds would be eligible for release to the NPMs according to the original schedule. However, this would be for future sales that they would then be required to make the fee.
So you're not trying to take the money that's currently in escrow,
No, ma'am.
but you're changing the terms of the agreement that they agreed to when they became.
No, there's no agreement with the non-participating manufacturers. This would now say, instead of the escrow deposits that you've been making going forward, you would now have to pay the equity fee.
Okay. And then finally, I'm sorry, because I'm not sure that my actual question was answered about the product itself, because people know cigarettes are dangerous. There are warning labels on there, and people know what the potential harms are, and they choose to do it anyway. So why are we punishing the manufacturer for producing a product that's operating and functioning the way it's designed to function?
May I answer that question? The product, as it is designed, costs the state a lot of money in Medicaid costs and other costs to our health care. And so the state is looking, in this bill, we're looking to recoup some of those losses that we have, because the state pays a lot of money to deal with the cost of tobacco addiction.
You usually don't ask a lot of questions, so go ahead.
Thank you. But that would be the case with, let's say, obesity. Are we going to charge the fast food companies a tax for making us obese when we choose to eat bad things? I'm just concerned about the overreach of charging when people have made a conscious decision to smoke, and then we're charging people more or charging a tax to recoup Medicaid money. That can go to any industry.
Well, I would say that we've already made the decision that it is sound public policy to impose this fiscal burden on the manufacturers of this harmful product, but are now broadening the scope of the manufacturers who are required to make the payment. We've already answered, I think the heart of your question is, where should the burden be? On the public that buys this product or on the manufacturer of the product?
Thank you, Madam Chair.
I have Delegate Morgan, followed by Chisholm.
Thank you, Madam Chair.
You're welcome.
Piggyback on what my colleague from Prince George's County said. I mean, there's a lot of products out there that are bad for you, like cheese. Cheese. Nah, I'm telling you, cheese, because the public health around heart disease is pretty vast and expensive on Medicaid. But you said something earlier about leveling the playing field. So my understanding of the original suit, and I grew up in Southern Maryland, tobacco farmer and stuff, so we paid attention to this stuff. I thought it was because the original manufacturers were lying about their product. They were harming children and saying it's, it's good for you, And they lied about it for years, and therefore that's the reason why the settlement took place and stuff. So how are companies that have never done anything wrong, because I'm under the opinion the AG's office has never sued any of these companies, correct?
We have not been able to file a suit against these companies, correct?
So how's that leveling the playing field if a few companies like Philip Morris and Marlboro did many bad things and said bad things and lied to people versus companies that haven't lied at all and met all the disclaimers and lived up to their contractual agreement? How's that leveling the playing field?
Go ahead. As I said earlier, there are a lot of restrictions on the participating manufacturers. They can't advertise at ball games. They can't have billboards outside. They can't do a lot of things now, and a lot of those are due to their past misconduct. However, I would push back against the statement that the NPMs have done nothing wrong. They're still putting out a product that harms children and harms the intended consumers of the product, and just as participating manufacturers pay the state in order to compensate for the health care costs imposed by their product, NPMs should have to do the same.
Very harmful, just like Vermont cheese, I'm sure. Thank you.
Thank you, Madam Chair. That's one of those rare times in this committee where everybody's got the same questions.
I wonder why.
But I do wonder, why not just ban it completely? If we know it's causing all these problems.
Would you vote for that?
No, I don't. No, because I believe in consumer choice and making educated choices, which is what people are doing now. Nobody, I mean, there's not a single person on the face of this or in this country that doesn't understand that cigarettes are very bad for you. And I think that's why you see a generation that's not using them as much, because they understand this. But if we really think it's this big of a problem, are we not banning it because it's a money coming in, or are we afraid you can't ban it? We try to ban a lot of other things here. So is this just a open spigot that's been open for so long? Now we're looking for more people to turn on to that spigot.
Well, Delegate, the difference with this product and other products is that it has a nicotine, which is very highly addictive. And I think we all know people, even in this day and age, that want to quit smoking cigarettes but can't because of the nicotine. And that, I love Vermont cheese too, and I could have it or not have it, but because it is an addictive, I have it at different times and don't have it at different times. And that's really the difference with this product. It is super addictive, and people get hooked on it who want to quit and can't. My father was one of those people. And he tried desperately for 30 years and just couldn't do it.
And I hate smoking. It drives me nuts. But my point is, do you believe there's anybody out there that doesn't know that nicotine is addictive?
That doesn't mean they're not addicted to it, though. You can know but still be addicted to it.
Thank you, Madam Chair.
Martinez.
Madam Chair. So I was 2 years old when this master settlement was signed. So I'm the generation that grew up with all of the benefits of having the restitution fund and all the investments around, not smoking and the Truth campaign. I remember seeing those commercials, and they had T-shirts and all the things, right? And I don't smoke cigarettes now. But my question, I guess, is I also was a generation that understood fairness. And what I could see here is that there is a pot of money available potentially, and we are trying to pursue it. And I'm trying to understand, what would we do if we got that $900,000? What would that investment be?
Sure. Thank you so much for the question. This is, the way we've directed it in the bill is to go specifically into the Department of Health, into the Tobacco Control Program. And so what they do is that they fund the Quit Line, 1-800-QUIT-NOW, which offers free nicotine replacement therapy and counseling to help people quit. It funds advertising in the state to counter industry marketing and to be able to say, hey, don't ever start, as well as enforcement checks. So making sure that our retailers are not selling to people under 21. You all did great work on that bill last year, but there needs to be funding and a part of that. So overarching, supporting our communities. Thank you.
I have another question, Madam Chair. Thank you. I'm getting the Terry Hill special. Because the way I feel around the non-participating.
That was said with lots of love.
Oh, for real? So I guess, for me, with the non-participating manufacturers, they've had to follow the guidelines that came after the master settlement. And so if there was some damage caused because of their advertising, because of the way they were doing this, couldn't we get the money in escrow? Couldn't you all sue and garner that money?
Well, I would submit that the harm is caused by the sale of the product.
Fair. I think we could debate that any day about any product, right? But we allow it. And so I think the harms that are caused, we have acknowledged, right? They're on the packaging in bold print that this will cause cancer if you smoke it, and people still spend almost $7 a day buying packets of cigarettes. More than that, right? With the taxes that we impose on it as well. So it's very well known to anyone who can read that cigarettes cause cancer and cause harm. I'm not saying that we should not fund to a certain degree the impacts of that, right? I'm just simply saying for the non-participating manufacturers, I feel it is really disingenuous to now say, hey, we're going to change the rules, guys, because you all have $900,000 in escrow that we potentially want to do all these additional programs with. And so I just find it concerning that this is the way we would do business here in the state of Maryland.
If I can take it.
Go ahead.
Oh, sorry. Delegate, as you said, if the non-participating manufacturers were to engage in fraud or deceptive marketing or something like that, you're right, we could file a lawsuit and go after the escrow funds. However, this bill does not go after the funds that are currently in escrow. What the NPMs are doing is taking the fact that they don't have to make payments to the state and undercutting the participating manufacturers. So they're just selling cheap cigarettes, and we all know that there's a direct relationship between the price of the cigarettes and the appeal or the ability of youth to get to them. So that's why we're saying that not going after the escrow accounts, but going forward, that we would now put both the participating manufacturers and non-participating manufacturers on a level ground, saying both of them have to make payments to the state.
So this, in a sense, is trying to create like the cigarette affordability board? Like, are we just trying to regulate the cost of cigarettes to make, because the thing is, there's going to be a market for it, right? Folks have the ability to shop around and be able to have the enterprise do their thing. And I think we should not get in the business of price matching for cigarettes. If that's the intent. If it's not to get the money and it's to just level the playing field, I find that a little ridiculous.
So I would say it's multi-stepped. One is that there's been some, I would call it financial shenanigans. I'm not a financial person, but being able to falsely kind of decrease the price of some cigarettes. And so we'd like to bring that up to par because people are very price sensitive. And we would also say that it's important to invest and gain those revenues back for healthcare. But thank you.
Billy O'Reilly.
Madam Chair, thank you for coming up and being part of the panel today. I do have big problems with this particular bill, and a lot of my colleagues have already stated a lot of really good reasons. The product is legal currently, correct? Mm-hmm. So, and there was a deal made, and now we want to go back on the deal. So that's the second issue. So let me ask you, so we've actually, I think Delegate Martinez mentioned it, we've taxed this industry quite a bit over the years. Do you have data showing that, because I have heard that the data shows that cigarette use in the state of Maryland has actually gone down because of all of these issues. So do you want to come back? This is the question. Do you want to come back and change this because you're losing money, or the budget deficit is you're afraid that the money's going to be taken there, or how can you go back on a plan when it is a legal product? And that's my issue. I mean, can the Maryland General Assembly at any time just go ahead and say, hey, we're going to make it really bad for the person who's manufacturing something on a legal product.
Well, if I might, just to clarify one more time, there was no deal with the non-participating manufacturers. The General Assembly passed a law, and the General Assembly could pass a second law, but there was no deal with them.
Agreed. And, yes, has cigarette smoking decreased? Wonderfully, yes. Unfortunately, there are still people who smoke cigarettes. We still see the health outcomes, and we have to continue to find ways to address that. And as well as to come back and say, we're still sending a lot of money on Medicaid right now. How can we continue to address how much of that comes from cigarette users and tobacco users? And so really the address of this is looking at how can we continue to, look at making investments in this space and make a change. But thank you.
Okay, all right, thank you.
All right. Thank you so much. I don't see any other questions. Let's go to the unfavorable. Michael Johansson, Eric Estes, Ralph Brown. We still have, and Dustin McDaniel. Then we have a favorable after that, okay?
Madam Chair, Dustin go first, our virtual witness?
Sure.
Does that work?
Absolutely. A favorable after that, okay? Can you turn it down, please? Are you ready?
There he is.
Good afternoon, sir. How are you?
I'm very well. Can you hear me?
Yes, you can get started.
Thank you so much, Madam Chair, members of the committee. My name is Dustin McDaniel. I'm co-chair of the State Attorney General practice at Cozen O'Connor. I served 2 terms as the Democratic Attorney General of the state of Arkansas and 4 years as the Democratic co-chair of the Tobacco Project at the National Association of Attorneys General. I'm here to testify in opposition of HB 870. Tobacco is, in fact, a harmful and addictive product that should be taxed and regulated heavily. But so long as it's legal, it should be taxed and regulated fairly. Excalibur Tobacco and other NPMs supported your tobacco increase last year and would support more, but escrow payments are neither taxes nor fees. Escrow funds are held in trust in case of future litigation. If the state is prepared to declare today that no future lawsuits will be filed and escrows are no longer needed, which is what HB 870 effectively says, then it should be amended to include a release of claims and a refund of existing escrows. Big Tobacco was sued by state attorneys general for the lies that they told consumers. And while Medicaid was a part of that case, it's not a significant part of the underlying settlement, which is why that money doesn't go into your Medicaid trust fund for federal match. Excalibur was not even formed at the time that the MSA was formed, and Big Tobacco made their settlement in order to get out of the lawsuit for the claims that were actually brought against them. They pay Maryland $160 million a year for that settlement, and it ended that litigation. Today, the proposal is to impose a legislative settlement on the companies that were either not parties or didn't exist at the time of the settlement, and skipping the little step of actually filing suit, proving claims, and justifying a settlement. Every state in the country that has considered this proposal, including Maryland, has rejected it, with the exception of Oregon, and their equity fee was struck in court last year. And respectfully, this bill should not advance as in its current form, and the MSA and the escrow obligation should be honored going forward.
Thank you very much. Next, please.
Madam Chair, members of the committee, my name is Eric Estes. I'm General Counsel of Excalibur International. Prior to joining Excalibur, I was in charge of Arkansas's tobacco litigation and enforcement efforts under Dustin McDaniel. In total, I've spent 20 years focused on tobacco regulation and policy. Cigarette smoking is unhealthy. No one on this panel is going to disagree with that assessment. Indeed, that's the very reason that cigarettes are so heavily regulated and taxed by the federal government and by states. This bill, however, does nothing to change that. Despite allegations to the contrary, it does not affect price, it does not restrict marketing or sale, and it does not limit or ban menthol or other flavors. As a matter of policy, Excalibur does not fight taxes, marketing, or flavor restrictions, as they have historically been applied equally on all manufacturers, regardless of size or MSA status. This bill, simply put, is an outlier. It relates only to those companies who have committed no legal wrongdoing, did not bring about the need for the MSA, and comprise only 1% of Maryland's tobacco market, which, like all tobacco markets, is decreasing in size and scope each year. In all, this bill does one thing. It changes the rules under which Excalibur and NPMs have legally operated for the last 25 years, and does so without any allegation, much less proof of wrongdoing. There is no need to level a playing field in Maryland. That playing field is level and, quite frankly, always has been. In fact, with 99% of all cigarette sales in Maryland, the playing field is, if anything, tilted in favor of the large tobacco manufacturers who brought about the need of the MSA at the expense of smaller, independent, privately held companies whose sales are 1% of this market. Thank you.
Thank you. Next.
Thank you, Madam Chair. My name is Ralph Brown. I'm the Vice President of Governmental Affairs for Shine International. Shine International is a small tobacco company located in rural North Carolina. We were formed in 2002 and are a non-participating non-manufacturer in NPM as defined by the 1998 Master Settlement Agreement. The issues pertaining to the Master Settlement Agreement, MSA, are intricate and involve numerous parties, including 47 states and at least 3 distinct types of tobacco manufacturers. Advocates for HB 870 assert that it will establish a fair playing field between participating and non-participating manufacturers. However, they fail to acknowledge that the playing field has been equitable for the past 25 years. The MSA was meticulously crafted to level the playing field for non-participating manufacturers by mandating annual contributions into escrow accounts from non-participating manufacturers, NPMs. As explained in the MSA, Maryland's existing MSA legislation effectively and fully neutralizes the cost advantages experienced by non-participating manufacturers compared to participating manufacturers. Furthermore, proponents overlook the existence of a third category of tobacco manufacturers, exempt manufacturers, who pay significantly lower MSA charges than NPMs. Notably, Liggett Vector's own SEC filings reveal that its MSA exemption is worth over $100 million. Consequently, HB 870 does not achieve a level playing field among participating, exempt, and non-participating manufacturers. Instead, it would exacerbate the disparity between NPMs and exempts contribution. In our view, HB 870 will not provide the benefits that proponents have described. While the bill imposes a fee on a small group of manufacturers that sell cigarettes in Maryland, the state is projected to lose over $1.5 million in 2026 as HB 870 is enacted. By imposing a fee on targeted group of manufacturers, the fee is likely to drive smokers to larger cigarette manufacturers that are not subject to the fee. This would eliminate competition and reduce the state revenue. If the state does want to do something to prevent smoking, I sit here today before you asking you that you tax all products fairly and equitably across the board. Increasing cigarette tax would be the most fair way to do this and accomplish this, is to tax all products sold that are cigarettes. Then you could achieve the budgets and the dollars that are necessary to reduce smoking in this state. Thank you.
Thank you, Madam Chair. I'm Mike Johansson on behalf of Excalibur International. My little Google phone says that restitution means recompense for injury or loss. The Cigarette Restitution Fund was about the bad guys paying for their bad acts. And guess what happened when they settled? They didn't pay any money at the time of settlement. They agreed, we'll pay when we sell more cigarettes. That was the deal that they reached. And that same deal said, oh, by the way, since there are companies that aren't existing today or aren't part of the settlement, we want to make sure that the state either gets them into the MSA, which means they participate in the MSA, or you have an escrow account. The bad guys negotiated the deal that the Attorney General's office says they don't like. Proponents suggested it harms children. The American Lung Association testimony says the big challenge in schools is vaping. and flavored vaping. There's no reference to non-flavored cigarettes in their document. The cigarette restitution fund, if it got this $1 million, that would change the cigarette restitution fund by 1%. That's what this discussion is about. The harm tax for current harm and current persuasion or disincentive to smoke is $5 per pack. You raised it $1.25 last year. That's for current harm. The bad guys are paying for past deeds that they've had the ability to pay for over 25 years instead of paying it back then. This other issue that's referenced multiple times in proponents' testimony is the windfall for the NPMs is the interest earnings on their escrow accounts that they get to use to reduce their prices for cigarettes. 5 years ago, interest rates were virtually zero. Today, if you look at your own bank account, if you get 3%, you're pretty good shape. So this $1 escrow fee could generate 3 cents for every dollar that they put in. That's what they see as the big shift between the participating manufacturers and the NPMs. So we respectfully would ask you to vote unfavorable on the bill.
Okay. Delegate Taveras.
Thank you, Madam Chair. I'll be quick. I mean, I remember getting my first pack of cigarettes from an ice cream truck off of 142nd Street on Broadway. But I have a quick question for you guys. Does Excalibur and Excalibur companies make vapes?
No, ma'am, we do not.
Thank you.
Any other questions? Seeing none, thank you so much.
Thank you, Madam
For
Chair.
being here today.
Thank you, Dustin.
We're going to go back to the favorable. We have two virtual, Kristen Jemison and Alex Casper. And these are our two last witnesses, and then we'll be done with our work today. Go ahead. And thank you, everyone, for being engaged and being present. Really appreciate it. Let me know when they're up there. Good afternoon, Ms. Alex Casper. Will you go ahead and give us your testimony?
Sure.
Thank you.
Thank you, Madam Chair, members of the committee. Sorry. I've been struggling with a cold, so I'm losing my voice a little bit. Thank you.
It's okay.
Thank you for the opportunity to make comments. My name is Alex Casper, and I'm the Director of Advocacy for the American Lung Association. We submitted our written comments, so I'll keep my comments brief. We support House Bill 870 for all the reasons that my colleagues earlier shared, and thank the sponsor. We did submit written comments, and in those comments, I think were earlier referenced. It may have been taken a little bit out of context as we were trying to paint a larger picture of tobacco use in the state. I will note that, tobacco use kills an estimated 490,000 Americans and 7,500 Marylanders each year. The Tobacco Prevention and Control Program is integral, but we're developing educational programs to prevent people from starting smoking and helping them when they need to quit. We believe House Bill 870 is a strong bill that ensures all manufacturers of cigarettes who sell their products in Maryland are paying their part by requiring them to make payments to the state, and those payments are invested in tobacco prevention and control programs. We encourage a favorable report, and thank you for the opportunity.
Feel better.
Thank you. It's just my voice.
Well, drink lots of tea and honey, as my grandma used to say. Next, please, I believe, is it Kristen Jemison? Good afternoon.
Hi, yes, good afternoon, Madam Chair and members of the committee. I'm Kristen Jemison, Regional Advocacy Director for the Campaign for Tobacco-Free Kids. I'll keep this short and just echo my public health colleagues. We know that tobacco use remains the leading cause of preventable death in the United States, and we believe this bill helps enable important additional investments in the Tobacco Prevention and Control Program in Maryland. We're one of the leading advocacy organizations working to reduce tobacco use and its deadly consequences. We urge you to support House Bill 80 and encourage a favorable report from committee. Thank you.
Thank you for being with us this afternoon and for being patient Are there any questions for this panelist? This panel? Seeing none, thank you so much for being with us. Again, hope you feel better, okay? And for everyone that waited patiently, thank you so much for being with the Health and Government Operations Committee today. This actually concludes the bill hearing on House Bill 870, and it concludes the work for the day as well. Can you please take a